Hello, I'm Robert Hardesty, a board-certified plastic surgeon practicing here in Riverside, California. The topic today is the treatment of asymmetric breasts. Believe it or not, most ladies, over 90% of them, have asymmetric breasts. Why is that? Well, when we are formed and the sperm hits the egg, we are formed like a clamshell. Or we come around like this, that creates a tube where our mouth and our anus is. So sometimes these things don't line up. And actually, if you look at most people, you do a split image of their face, they're left and right asymmetric. So it's not unusual. Yet most women feel bad that they are asymmetric. Well, that's just the way it is. Fortunately, we have ways of fixing that. So, what are the asymmetries we see? We see differences in the inframammary fold or the breast crease. Most often we see differences in volume. You can have a chest wall that sticks out called a pectus excavatum, or it can be sunken in, a pectus carnatum. You can actually have absence of the breast and the muscle on this side, and that's called Poland syndrome. You can also have sagging, asymmetric sagging. One breast sags more than the other. We can have different sizes of the nipple-areolar complex, one side to the other, or we can have a combination. So, what do? The first thing is, it's like building a house. We need to get the foundation solid. So, if there is an asymmetry of volume, we want to know what that volume is. We can do a bilateral augmentation and put a little bit more on the left side if it's smaller than the right side. So first of all, how do we determine that volume difference? I like to use a three-dimensional, simple approach. This is a measuring cup. It has ounces and cc's. This is a nylon with rice in it. So what the ladies will do in their current bras is make sure that the straps are equal, put the rice volume in to make sure that the breast volumes are equal. Now we know where to start. Now we can add equal amounts to each side if we want to have an increase in size, or we can reduce the larger size, or we can add with either a normal saline implant or a silicone implant. The positives of a normal saline implant is that it's adjustable intraoperatively, so that we can add more or less as we're sculpting that breast. Okay, what happens if we have a sunken chest wall or a chest wall that's sticking out? Well, we can correct some of those by putting in a custom-made silicone sheet if we need to. It's unusual, but we can custom make it so the chest is more even. Okay, what else do we do where there's asymmetry maybe in width? We can go to the profile of the breast implants. For instance, these three implants are all the same volume. This is the high profile, a low, medium profile, and a low profile. If I want to make the implant, or the manufacturer wants to make the implant the high profile, we'll go ahead and do this. Thus, if one breast is wider than the other, we can put a different profile based on the shape of the breast width. We can also put in a shaped implant. These implants, gummy bears, will go ahead and conform in the body. So if you're standing up, they'll be like this. If you're laying down, they'll puddle like a normal breast. But sometimes we'll use highly cohesive breast implants that will go ahead and be form stable, so it will allow the shape to remain even in the recumbent position. Now, in extreme cases where patients don't have any breast tissue or lack of the muscle, we'll put a tissue expander in. What is that? Well, it's like pregnancy. It's a deflated saline implant that has a valve on it, and every week you come to the office and we fill it up until we stretch the skin, so now we can equalize the breast out. That's done in rare situations cosmetically, but done quite often for reconstructive surgery. Now, what about the sagginess and the asymmetry of the nipple-areolar complex? Well, we treat that by a mastopexy. That's basically a breast lift. That can be an incision just around the nipple. It can end up being down the center or an anchor, depending on how much extra skin we have to take. And in doing so, we have cookie cutters, so we can make the nipples equal. So in conclusion, most women are asymmetric. They only vary by the degree based on the anatomy and the genetics. Our job is to go ahead and try to make the breasts as similar as possible using our techniques. I often tell my patients I can make sisters, not twins.